today I'm going to be looking at very short, briefly, a look at tools for analysis of micronutrients, biomarkers, and interpretation of etiologic predictors of anemia. So we've talked about a lot of predictors. Now, what tools do you use? And so that's one of the things that we're going to discuss today. And it's going to be a rather short presentation, but it will also be interactive, and I will stop and pause for questions if you have questions for us. I have no conflict of interest. So causes of anemia. I think we've gotten a lot of overview of this, but I just, all colleagues or presenters before me have mentioned this. Just to encapsulate, the causes of anemia can stem from many factors. Here there is diet, there is infection, there is hemoglobin disorders, and there is also inflammation. So this actually captures the ecology of individuals. You know, diet is the environment, the food systems, what it provides. Infection is infection in the environment. And then genetics, that's how we are born, our genetic constitution. So if one is to look at predictors of anemia, one needs to also look at these dimensions. So this just tells us how multifactorial or multi-causal anemia is. Just a few examples here. And then when we look at iron deficiency anemia, which is quite much like what we normally look at in terms of coming from the program side or intervention side or causal side. It also has multiple causes. On this slide, we show so many things coming from internal ecology of the individual, from reduced absorption, inadequate dietary supply, and then also reduced red cell production. This is biological to the level of the body into the systems in the body, and then also demands, you know, so that again brings in the life stage. So for example, we have young children, their life stage, there is demand for iron for normal growth, and then also their systems or their gut systems are probably not also developed enough to absorb iron from the dietary sources. So anemia is just a reflection of the ecology. It's a bioindicator because it's affected by so many other factors. So I think this, I'd like to just give a quick very contextual and important overview of malaria and anemia. And on this slide, we show the red cells. On the left side, we have normal red cells. Everything is going on fine. There is increased iron availability. If we look at the bottom, there is bone marrow where red cells are produced. There is everything is working well. And there is recovery from anemia. And then there is also hepcidin, which is a master controller of iron, also is suppressed. So when this is the normal physiologic state where there is no pathological problems. However, when there is an infection like malaria, a lot happens to the cells. First, malaria infection, there is red blood cell loss. So again, right there, the infection is targeting the cells that carry the oxygen for function in the body. And there is also high hepcidin. So again, in that process, there is inefficiency. The cells cannot absorb iron. So malaria actually has its own dimension of impacting that. So this is also one important factor that we need to consider. Again, a contextual factor like malaria has its own bearing on anemia. So my few slides I've mentioned here is how it just embodies how contextual factors matter. So contextual factors that can come from two different dimensions, internal or external. So we have the internal milieu, that's the health status of the individual, and external, the external environment. So that's one thing that we always consider. So this diagram was, we pulled it from one of WHO's publications from the Iron Deficiency Anemia Assessment and Prevention. It's a report that published in 2001. And actually it's very, very pertinent to what we do here and what we are discussing. It just gives you a diagram of two settings. Setting A is high prevalence of iron deficiency, high prevalence of iron deficiency anemia, and then setting B has a moderate prevalence of iron deficiency, low prevalence of iron deficiency anemia. So when we look at the boxes inside, you see that the anemia, the rectangle in there, is of the same size. But in setting B, the proportion of anemia due to iron deficiency is very small compared to setting A. This just tells you that you can have anemia, comparable burden across multiple or different settings, but the drivers are different. So interventions that are rolled out will have different impact, although the burden is the same. And so this brings in one dimension of modifiers and confounders. And some of these can be due to inflammation, malaria, genetic disorders, and other factors. So this simple diagram just shows us how anemia etiology can vary from setting to setting, and then also impact of programs also will yield different, programs will have different impact depending on the setting. So these contextual factors are quite important. So then, in 2020, WHO guidance was released for the use of ferritin concentration to assess iron status in populations. And the key take-home here, there are a few take-homes here. Iron deficiency cutoffs were revised, and they said ferritin can be used to assess risk of iron deficiency as well as overload. But one key part was the acknowledgement, or based on a lot of research before then, that the need to adjust for inflammation. Again, inflammation is it captures the infection and body response to infection. So it does two things. The innate immunity the body puts out towards infection, and then also it reflects what other endemic infections are in the area. So that gives us a way to measure the environment piece in terms of health. But there is one dimension that comes up. We have different adaptations. So when a person lives in one area, they might have a different type of infection, or they have adaptations that they get exposed to a pathogen, they will not get sick or something. So these different adaptations and different contexts of infection brings the point that we also need to customize our interpretation. That interpretation, that one size doesn't fit all. Just from the previous slide where we said context matters when you are designing interventions, context matters when you are interpreting iron status, for example. So one of the key things that WHO report said that serum is an acute phase protein, as we know, and then concentrations are elevated by serum ferritin concentrations are elevated by infection. So it makes a problem a little bit more difficult because we have to also take account into this inflammation and infection burden. So two key indicators were biomarkers were mentioned, like C-reactive protein and then alpha-1 glycoprotein. Now, both capture infection and response to infection. So this is what we are trying to get to in order to be able to interpret iron data. So why is, what does inflammation do to key biomarkers like serum ferritin? And on this slide, we show you that when an individual is exposed to or is infected, indicators like CRP and AGP can increase over 200% within 48 hours. So this shows us that once a person, and then we also have ferritin, which is also acute phase protein also on the slide. So infection will temporarily increase ferritin status. So this is why if we are looking at infection and then ferritin, then we have to find a way of addressing the infection in order to get a clear picture of the deficiency, for example. So was one thing that when we are interpreting iron sufficiency, if we say a child is sufficient or not iron deficient, few questions come to mind. The first thing based on the WHO guidance is, was the indicator adjusted for inflammation? And then how was the data adjusted? This is just a few examples. And then in some ways, we also want to know, we have to show data on adjusted and unadjusted distributions in order to really capture prevalence. So this is some of the steps one would want to consider when it comes to iron deficiency or iron sufficiency interpretation. I'll show you one simple illustration of why this is important. So on this here, we show a relationship between inflammation and ferritin, which we use to measure iron deficiency. We have three individuals. Individual A, let's say this is a child. Individual A, individual B, individual C. The threshold for iron deficiency is 12. For individual A, there is no problem because when there is an infection, they are iron sufficient. So although their iron levels rise, it doesn't put them at risk or doesn't make any difference. But individual B, the iron level is below already, but then during infection, they temporarily get an increase in ferritin levels, and this will consider this individual child as not iron deficient. But that is a very transient response to that infection. So if we have a survey and you have more children of this, it's not giving you a true picture. So in order to really understand your data, we need to address for this transient infection response. So this is what we are trying to do in trying to address and interpret iron results when there is inflammation. So how do we calculate iron deficiency and iron deficiency prevalence in the presence of inflammation? So on here, On the left side is the WHO report, the thresholds for defining iron deficiency. However, in settings of inflammation, after we adjust for inflammation, we still use the same threshold. So this is what we are trying to do to diagnose iron deficiency. And then on the right-hand side of the panel is iron deficiency anemia. Again, after defining the iron deficiency, we also include anemia based on HB concentrations. And so based on that, to get iron deficiency anemia, you have to use ferritin that has been adjusted for inflammation and hemoglobin to define the threshold, define or diagnose iron deficiency anemia. So this is one example. So how do we put all this together? Our work has done a lot of work where there are multiple approaches, and a WHO report, 2020 report on ferritin guidance just said there should be an inflammation adjustment. So here our work, Brenda, which is biomarkers reflecting nutritional determinants of anemia, and I was privileged to be one of the first data people on there. We looked at data from many countries, and we came up with approach to address that. So the approach is shown here. To get an adjusted ferritin, we subtract out the influence of the inflammation. So this equation here is shown where we have ferritin, we subtract out the inflammation effects, and then in most settings in Africa, malaria effect, but that's another discussion point and coming up. So after all this, that's when you get the adjusted inflammation adjusted ferritin before we can interpret iron deficiency. So this is just the equation I showed you is not to, it's a lot of steps, but we've developed tools to help people. So you don't have to go through this, but this explanation is to help you, give you the background, why do we need all those steps. I have one slide that is quite interesting and important and pertinent to the Africa region, especially in malaria infection in children. There is a slide where from one of our studies in programs that we provided technical assistance to UNICEF DRC, and we show that in malaria infection state, children that are malaria positive have higher ferritin status. So malaria positive children are more likely not to be iron deficient. However, they have lower hemoglobin. So right there is telling us that their malaria status can put them at a risk of anemia, but not iron deficiency. This gives you just another contextual dimension of why infection is important. So the next slide is when you are looking at iron-related biomarkers, adjusting for inflammation matters. And this is one report, data from Malawi 2016 National Micronutrient Survey. We see that the prevalence of inflammation was in children, for example, the prevalence of inflammation was 57%. And so this important, the prevalence of inflammation, this high, we need to adjust for inflammation when looking at iron deficiency in order to see the bigger picture. So this brings us to the hands-on practice. All right, so we shared with you an app, and this app is from our work, and we did some more work and analysis, and then we just said, well, why don't you make it open source? This is an approach to make the data or the analysis be user-friendly. I do a lot of programming, I build programs, I build apps, and that's what I do, computational biology. But I just feel like not everybody needs that much detail. So this app was to bring it to the end user. So the next kind of app that we've been building is to have a way of encapsulating all this into one package where you can generate results based on those levels. This is not in the app stage, it's in the GitHub stage, which is programmers. It's called Statistical Apparatus for Micronutrient Biomarker Analysis, and we call the acronym is called SAMBA. We published a paper from that, and this was led by our colleague Hang-Chi Luo, also with a CDC, Emory Brenda team. And we also provided technical support on that. Some of us were co-authors on that app. So it also does more. There you can load 5 data sets, 10 data sets. You run it through and you can spit out so many data sets. So you can have data coming from household survey, clinic, small studies, all of that. So it actually scales what we are seeing up to another level. So it can generate visualizations, all of that. So this is just a way of packaging nutrition data in such a way that it can inform, it will be effective communication tools to help interpret a program of intervention program, and also to help generate advocacy tools for policy. So it's a lot we are doing. It's the space, there is a lot of innovation going there, and this is all open source, so that every country or in every program that wants to spend resources on that, you just need the time to train your staff, and a lot can be done. You don't need to wait. This was built by epidemiologists and statisticians, but with training, you don't need all that expertise, that skill set, but minimal skill set and training, it will help you. And also, it cuts down errors. So that's not gonna be, it's standardized. You know, once you select this population group, the thresholds that you're gonna apply will be the same. So it really is a standardization tool for micronutrient biomarkers. So with that, I'll end my session, and I'll welcome any comments or questions. Over. Thank you.